Good afternoon, guys. We've spoken about the most effective TRT. Now let's talk about the least effective. No, I'm only joking. So, when you come to the men's health clinic, it isn't a one-size-fits-all protocol. We don't have everybody on testosterone, cypionate, and HCG. We have the vast majority of people on testosterone, cypionate, and HCG because I believe it is the most effective method of normalizing your male androgen levels to within normal physiological parameters for long-term, sustainable, physical, and psychological well-being. There's a common misconception that testosterone cures life. Just increase the dose. Now, if low testosterone is the problem, yes, increase the dose. That seems very logical. Now, suppose you have a low libido despite having a normal testosterone level. Now, we'll get on to what is normal in a minute because there are some misconceptions. People have misconstrued what I've said, and what I believe normal is not what you think I mean normal to be. What am I talking about now? I was going to say something before. Let's do the normal now. Okay, what's normal? So, if you determine normal by the reference range, you will be doing your patients a disservice. Now, let's consider the fact that reference ranges are dropping. Now, we know that. We've proven that. There's research to back that up. And we've asked our guys to trawl through their records to find pathology reference ranges from a few years ago and compare them to pathology reference ranges from now. And if you look at the TRT best practice blog, that demonstrates it nicely in a table. It also shows the regional variation and the variation between countries. So normal, what is normal? I would consider normal. Wait for it. I would consider normal the testosterone level that you are supposed to have in your 20s. When you think about your timeline, you go through puberty, your testosterone spikes, and then it drops very slightly, and then it starts to drop from about 30 onwards by about 1% per year. That is a guide. It's not true for everybody. You can maintain a very healthy testosterone level through healthy lifestyle, nutrition, and exercise. However, you are fighting a bit of a battle in our rather polluted, poisonous world. However, there are some guys in their 60s with cracking testosterone levels. But conversely, testosterone levels are supposed to drop with age because you're supposed to make way for the next generation. You're supposed to retain the ability to procreate from a survival of the species perspective, but you're not supposed to be popping out kids or impregnating young fillies when you're 60 or 70 years old, unless you're Mick Jagger. I can't get no. So, yeah, testosterone levels are supposed to drop. So when we consider the reference range, unfortunately, the reference range does not take age into consideration. So the normal reference range is not a healthy reference range. Now, we'll actually take a little bit of that back. And some of the proponents of advocating high normal levels forever will go, no, you're wrong. But there are guys out there, 50s, 60s, who are perfectly happy with lowish testosterone levels. Is it because their expectations are less? Is it because they know no better? Know no better? Is that right? Could partly be that. It could partly be the fact that they're content. They don't want to be Randy Goat Boy. They don't want to be running 5k a Saturday morning at the park run. They don't want to be lifting heavy ass weights. They're quite happy. So you can't have this opinion that everybody should have high normal levels for long-term physical and psychological health. You cannot be happy unless you have high normal levels. Sorry, the dogs are a bit hankering for their run. So what's the aim of testosterone replacement therapy? Enough! The aim is to normalize your melandrin levels. So everybody wants high normal levels. I want high normal levels. My free T sits about 0.85. My estrogen's 109 at the moment. If I go any higher, my hematocrit spikes and I have to donate blood. So I know they are my perfect numbers for me. So how do you tell if your numbers are not perfect? Because your hematocrit rises, your HDL goes down, your LDL goes up, your blood pressure goes up. But somebody conversely may have a free T of 0.95, 0.7, 0.6, and that could be their perfect number. Because anything above that may cause deterioration of those physiological parameters that we've just mentioned. So normal, perfect. Normal and perfect mean the numbers that are right for you as an individual. Now we have reference ranges for a reason. That reason is because most people fall within that reference range. It's a 95% confidence interval. But nowadays it reflects a sick society. So what should we be aiming for? We should be aiming for high normal. Should we? We should be aiming for normal. Normal for you. That's what's important. So I've got guys, as I said in a previous video, who was running at about 0.9 something, flying, constantly flying, and it was too much for him. He ended up having a nervous breakdown. Now, does that mean that I would have a nervous breakdown with a free T of 0.9? My free T has been up to 0.9, and do you know what? Outwardly, cool, calm and collected. Inwardly, didn't like it. And anxiety. It was really weird. Really weird, because, you know, I'm alpha. I hit it down the gym. You know, I'd like to think of myself as an alpha male. Would I? I'm definitely not beta, but I mean, cool, calm and confident. That's how I want to be. So I find my free T about 0.85. As I said, my estrogen's normally about 100 to 110. That's where I feel best. Do you want to know my protocol? It's 12.5 milligrams, 0.1 mil of testosterone cypionate daily, 100 IU of HCG daily. That's it. That gets me up to 0.85, where I feel best. Don't need much, do I? Of course, my testicles are working. So that's good news. So it has to be right for you. That's what's important. So there is no one size fits all protocol, because you are all biologically unique. We all share 23 chromosomes, 23 pairs of chromosomes. Some of you are a bit deficient, not mentioning any names. I shouldn't have said that, should I? Never mind. But our genetics differ. We have different expression of genes, so you cannot have a one-size-fits-all methodology to how you practice. So everybody should be on testosterone, cypionate, and HCG. It doesn't work for everybody. It works for the vast majority of guys for the reasons discussed in the previous video. But I do have guys on other treatments. I do start guys on other treatments, but I made that decision it's a clinical decision. It's based on numerous factors. What's the second most prescribed TRT protocol at the Men's Health Clinic? It's testosterone, enanthate, and HCG. Why enanthate? Well, we used to use enanthate as our gold standard until we managed to gain, our wholesale company managed to gain an import license for cypionate. Because we were using it sub-Q, slower absorption, less E2. But we were finding a number of guys having local skin irritation and decreased absorption. So it was interesting, actually, when we made the switch, that testosterone levels went up. So there was an issue with the absorption with enanthate administered sub-Q in a minority. Now, if you only go by the research, testosterone enanthate is perfectly safe via the subcutaneous route, and it's effective if you go only by the research. But we've already discussed this. Research is inherently flawed, and clinical experience, I can tell you firsthand, and a lot of my guys can, that enanthate isn't always effective, and it can cause irritation and potentially predispose to infection, obviously, through that irritation. One of my guys didn't bloody tell me, but he was having issues, and he'd had a case of cellulitis about 3 times. So, yeah, according to the research, safe, effective, clinical experience, safe and effective in most people, but not everybody. Again, no one-size-fits-all protocols, no one-size-fits-all anything, because medicine is a practice, it's ever evolving. So why are some people still on enanthate? Well, because they've managed to get their GPs to prescribe their medication for them, which is brilliant news. Why is a private medical clinic allowing the NHS to prescribe medications for their patients? It's less profit for us. It's because we've always got the best interests of our patients at heart. Now, we could make that a rule, but we're not going to, because we want to make TRT affordable to as many people as possible. Doesn't mean we're not going to make a profit, because obviously we need to. But, the main amount of cash that comes to us comes because they are paying to see me. So it's my time and expertise, and obviously the clinic and all the overheads and Her Royal Highness's fee as well. Yes, miss. So yeah, we're delighted. And what does that signify? NHS GPs are willing to prescribe medication, and that really means that they're willing to take responsibility for that prescription, because if something happens, who's going to be on the chopping board? It's them, because they have signed the prescription. So they have confidence in the men's health clinic, which is absolutely wonderful to hear. So we've always been fully transparent about our practice for a reason, not only to establish trust in our guys, but also to hopefully change practice. And one of the ways that we're going to do that is raise our head. And people have tried to knock our heads off many times, and they'll probably continue, but you'll fail. But yeah, it's incredibly positive that we've got GPs prescribing for their patient that's on their heads. Wonderful. We've even had a couple of referrals from GPs to the men's health clinic, to a private clinic. That's amazing. So these guys, a lot of them are on sub-Q. Some of them have had to switch back to shallow IM because of the irritation. So yeah, enanthate NHG is the next most common TRT concoction. The next, the gel and HCG. Now the gel has some inherent problems. It's not dosed high enough, and there's the potential for decreased absorption. But if we go back to how I like to think about testosterone replacement therapy, it's maintaining function with HCG and topping up with testosterone. So in some of my older guys, that actually works really well with HCG and testosterone gel. The HCG works as the base, and the daily application of the gel gives them that normal testosterone, and it also gives them that sort of little spike, which in theory would mimic natural physiology. Again, in theory. So yeah, Sustanon. Does Dr. Stevens prescribe Sustanon? I do have a couple of guys on it actually. They are on every other day injections because of the prop ester, and they are nice and stable. And again, they're both on HCG actually. No, one's on HCG, one's not on HCG. So one's on Sustanon monotherapy and one's on Sustanon and HCG. HCG doesn't suit everybody. It's quite disappointing, because I've got my idea or ideology or whatever it's called, to have this maintaining function thing, but it doesn't suit everybody, unfortunately. So whether it's a control of E2, whether it's a dopamine spike in the brain or adrenals, I don't know. We can theorize, but we don't know for sure. But it seems to be, it seems to cause anxiety, irrespective of normalish estrogen levels. So it doesn't suit everybody. So after that, probably test SIP monotherapy, test E monotherapy, Libido. I have two guys on Libido. One's on 125, so 0.5 ml every week, and the other's on 250 once every 2 weeks, so 1 ml. And both of them are incredibly stable. It's a right pain in the arse, because obviously it takes a long time to get stable, and if you have side effects, then simple dose adjustment is it takes forever to stabilize, because of 5 half-lives. 30 days is the half-life, so it's 180 days, so almost half a year. So if you make a change to the protocol, it's going to take forever. So it's not wonderful, but I've used it in a couple of guys. Why have I used Libido? Because we started off using Libido, but we used it as per manufacturer, but it didn't work. Peaks and troughs. Can it work? Yes. Before the advocates of Libido say, "Oh, Dr. Stevens, I'm very happy." So I'm really pleased you're happy. But the pharmacology, the pharmacodynamics kind of doesn't really make sense. And in clinical practice, again, clinical practice, it's not effective. Can it be? Yes. Can you get stable levels if you do 8 weekly injections? Yes, but you're still going to get a peak and a trough. And if we're thinking about hormones, we need to think about them in a 24-hour period. Hormones don't care if you're at work, if you're at play, if it's whatever. So it's a 24-hour cycle. So that's what we should be trying to achieve. Stable levels, 24, 24, 24, 24, 24, 24, and ongoing. So yeah, both of my guys on Libido are both on HCG. Why do we prescribe Libido? Because testosterone cypionate, despite it being the gold standard, does not work for everybody. Who doesn't it work for? Well, we've got 2 guys who had single-figure SHBGs who just couldn't get stable. Numbers were fine. They just didn't feel it. So we switched them over to Libido, and whilst there was a titration process, which is a pain in the posterior, it has worked for them eventually, but it's not ideal. What else? We've got one person on HCG monotherapy. He's got an autoimmune condition, and he's intolerant of everything. So the only thing he's actually been tolerant of is HCG. So we've got him on, I think, 250 every day. He's okay. He's reasonably okay. He's not optimized, but he's better than he was pre-TRT with testosterone deficiency. So hopefully we're going to have a little play with Proviron next to see if we can bump up his DHT and make him have that qualitative improvement, to see if that brings about an improvement in his qualitative symptoms. So, what else? AIs. We've spoken about the use of aromatase inhibitors. We're not blocking, we're controlling. We are normalizing the testosterone to estrogen ratio for optimal health and well-being. Our average dose, 1.6 milligrams a day. So the premise behind TRT, as said ad nauseum, is normalization. How you view normalization, it's up for interpretation. I've already given you my argument. Testosterone 12, kill me now. Testosterone 15, kill me now. The BSSM guidelines aim for treatment, as discussed in the previous video, 30 to 15. Most people feel best 25 to 30, some 20 to 25. 20 to 15, you might feel okay, but I think you're missing the point a little bit. Your SHBG must be super low, and we want to get your SHBG up, and a good protocol will do that, as long as you reverse the other causative issues that might be contributing to your low SHBG, namely hypothyroidism, metabolic syndrome, diabetes, etc., and low testosterone, interestingly. So I'm sure SHBG drops as a result of low testosterone. We see it all the time. It's fascinating. So what are you aiming for with SHBG? Middle high would be wonderful. Middle is great. Low on a good TRT protocol indicates more than likely you've got another issue going on. Super high, again, hypothyroidism, liver dysfunction, cancer, gastric cancer. So it's not something to be ignored. You do need to address SHBG and look for causes that will hopefully be reversible. What else? Proviron monotherapy. Got an interesting case study to tell you guys about in the next few days. Again, it highlights the difference between theory and clinical practice. And there is a difference. There's a difference between adhering or advocating something according to the data and having a progressive approach and realizing that there are no absolutes. Super important to realize there are no absolutes. So the theory behind Proviron we'll discuss in the next video, and the case study that we've just done will be quite illuminating. Proviron is like Marmite. You either love it or you hate it. And yeah, we've had very, very mixed results with Proviron, despite the science stating that it will improve the testosterone to estrogen ratio. In clinical practice, that's not always the case. So it comes back to this idea again, ad nauseum, that you cannot have a one-size-fits-all protocol or approach, because we are all unique, not special.